Thank you, Chairpersons, for your kind words. At the outset, I am highly obliged to Dr. Alok for giving me the chance to come here and share my views with you all. My topic is hypertension in elderly. Now, the hypertension is the commonest cardiovascular disease worldwide, and its incidence increases with increasing age. Its incidence is about 27% in those below 60 years, and it increases to 74% in those above 80 years. According to the Framingham Heart Study, more than 90% normotensive at the age of 55 years, they become hypertensive in due course. Approximately 60% become hypertensive at 60 years, and 65% men and 75% women, they became hypertensive at the age of 70 years. Elderly are the people more than 60 years of age. They are subdivided into young elderly, 60 to 70 years, middle elderly, 70 to 80 years, and old elderly, above 80 years of the age. The India's population trajectory shows that there is a 55% increase in total population in between 2000 to 2050. In absolute number, between 1008 to 1572 million. And increase in more than 60 years, that is elderly population, is 326%. And in oldest elderly, it is 700%. The elderly comprises a diverse population. They may be fit or frail, might have complex comorbidities or having single or no disease. They may be mentally sound or have dementia, may have family support or caregivers, or may not have, may be financially sound or may be poor. The most of the studies guiding management of hypertension, they exclude elderly, especially those above 80 years of age and frail. And it leads to the treatment controversial in elderly. UKPDA, SHAPE, SPRINT, CISTURE and HYBET, these trials, they show CVD benefits in treating hypertension in elderly. The pathophysiology, there is some specific mechanism in elderly, like mechanical hemodynamic changes, arterial stiffness, neurohormonal and autonomic dysregulation, and aging kidney. With aging, what happens? The arteries stiffen with fracturing of the elastic lamellae and intimal hyperplasia in aorta. The stiffened arteries, they produce decline capacitance and limited recoil, which leads to a difficulty to accommodate volume changes throughout the cardiac cycle. With aging, both systolic and diastolic blood pressure increases. This starts from the age of 30 years onward. But above 60 years, central arterial stiffness predominates, leads to the increased systolic blood pressure and decline in diastolic blood pressure, which again causes isolated systolic hypertension and wide pulse pressure. This wide pulse pressure increases with age independently of the mean blood pressure or other determinant factors. The NT-proBNP, it is a marker of arterial stiffness in elderly without CVD. It is possibly positively associated with systolic blood pressure, and there is an U-shaped association with diastolic blood pressure. Endothelial dysfunction, here there is increase in endothelin 1 and reduced bioavailability of the nitric oxide, which leads to the affected arterial dilations. There is decreased renin angiotensin aldosterone system in elderly. The plasma renin level, it reduces to 40 to 60% of the younger level at the age of 60 years. There is decline in the plasma aldosterone level, which predisposes them to drug-related hyperkalemia. There is reduced varoreflex sensitivity and loss of arterial compliance in elderly, which leads to the orthostatic hypotension, which occurs in about 18%. It leads to increased falls and cerebrovascular events in the elderly. The postprandial hypotension, it is an under-recognized cause of syncope in elderly. Elderly with heart failure, Parkinson's disease, end-stage renal disease, on dialysis, autonomic dysfunctions and frailty, they are more prone for postprandial hypotension. Its mechanism is unclear, but the reduced sympathetic response to a meal is proposed for it. If it occurs, Then for treating, we have to advise patient to increase water intake before eating, or they have to take 6 smaller meals in place of 3 larger meals daily. And frail elderly, if they start walking, then they will increase their postprandial BP and heart rate. Aging kidney, there is increased salt sensitivity due to reduced activity of sodium, potassium and calcium adenosine triphosphate pumps, which promotes vasoconstriction and vascular resistance. The hypertension, it causes increased risk of ischemia and hemorrhagic strokes, vascular dementia, Alzheimer's disease, coronary artery disease, atrial fibrillation, CKD and retinal disease in elderly. There are many guidelines. I am just giving some important guidelines like Canadian guidelines in 2017. I am sticking to the elderly population only. According to them, in 60 to 79 years, the optimal goal should be less than 140 by 90 millimeter of mercury, and in those who are 79 years, it should be 150 to 90 millimeter mercury. Same year, ACP, American College of Physicians and American Association of Family Physicians, according to their guideline, in those who have 60 years, it should be, goal should be less than 150 by 90, and if TIA is there, then it should be less than 140 systolic. ACC, AHA, they gave in those above 65 years and ambulatory, these patients, the goal should be less than 130 systolic blood pressure. But in those above 65 years and having high burden of comorbidity, limited life expectancy, here clinical judgment is important, patient preferences is important, and here physician has to assess risk and benefit of reducing blood pressure. According to ESC and ESH European Society guidelines, which came in 2018, in those above 60 years, the goal should be less than 150 by 90 millimeter mercury. These differences in the optimal goal, they give controversy on the optimal BP targets. But as a geriatrician, we feel that the lower tolerated goal is better in elderly. As low which is tolerated is better, because they are vulnerable to the orthostasis, fall and renal dysfunction when we reduce blood pressure more. SHAPE, CISTURE and high weight trials, there is significant CV benefit on lowering systolic blood pressure in associated systolic hypertension. SPRINT trials, according to it, they got benefit of lowering systolic blood pressure less than 120 millimeter mercury in those who are 75 years old. NHA NES data analysis, they give that in slower walkers, which is a diagnostic or which is a criteria for frailty, that is if the person is having less than 0.1 meter per second speed of walking, here increased systolic blood pressure and diastolic blood, that is more than 140 by 90 millimeter mercury, they were not associated with the mortality. The BP reduction in frail elderly may be harmful, so frailty must be taken care of. According to the HOPE 3 trial, no benefit of reduction of blood pressure less than 140 by 90 millimeter mercury in patients with intermediate risk, not in high risk. So one size may not fit all. ESC/ESH guidelines are more feasible in elderly with poor vascular compliance, orthostatic hypertension and increased pulse pressure. The challenges in the geriatric cardiology, there is difficulty in making decision not on the age alone but on overall medical, physical, social and mental characteristics of the patient. So there is a scope of the personalized medicine in elderly. Here the treating physician, he must be mindful of the certain issues like cognitive impairment, comorbidities, polypharmacy, orthostatic hypertension, falls, gait speed, medications cost and their side effects, incontinence, fatigue, visual and auditory limitation, social support, caretaker availability and frailty. So the treating person, he should be careful of these issues also. And he has to rule out pseudo-hypertension, masked hypertension, situational hypertension and secondary causes in resistant hypertension. So now to manage. The non-pharmacological interventions, they are very important. Even in 2023, European Society gave the guidelines. I think it has to be dealt with detail in the morning sessions. So I am just enumerating them. The regular physical activity, weight control, suggestion of the smoking, reduction of stress, reduction of the excess alcohol intake, DASH diet, low sodium and potassium, calcium and magnesium supplementation, consumption of the probiotic, fiber, flaxseed, increased protein intake, consumption of the garlic, dark chocolate, fish oil, tea, coffee, etc. Contributing comorbidities like sleep apnea, renal artery stenosis, prostatism and primary aldosteronism, they should be taken care of. And drug review, it is very important in the elderly. If they are taking NSAIDs, steroids, angiogenesis inhibitors, tyrosine kinase inhibitors, atypical antipsychotics, antidepressants, amphetamine, decongestants, immunosuppressants on HRT or herbal supplements, we have to take care of. If they are taking these drugs, they may cause hypertension in them. Now to pharmacological interventions. There are certain important factors to choose which prior to choose drugs. These are very important, like comorbidities, frailty, ability to follow instructions, complexity of the current regimen, supporting care like spouse and family, electrolyte imbalance and renal functions. The thiazide diuretics, AC inhibitors or ARBs and calcium channel blockers, they are the primary drugs for monotherapy, and for combination therapy, calcium channel blockers plus AC inhibitors or ARBs or calcium channel blockers plus thiazide diuretics. While up titration, we should take care of the orthostatic hypotension, renal functions and hypokalemia. Beta blockers, they should not be prescribed unless indicated by the comorbidities. Loop diuretics and alpha blockers, they are best avoided in elderly because they increases the risk of fall. In isolated systolic hypertension, calcium channel blocker or thiazide diuretics are indicated. And now to conclude, hypertension is the commonest cardiovascular disease worldwide and its incidence increases with increasing age. The India's population trajectory shows a higher increase in the elderly populations and hence HTN. Most of the studies exclude elderly, especially above 80 years of age and frail, so making treatment controversial. The specific pathophysiology in elderly are arterial stiffness, neurohormonal and autonomic dysregulation and aging kidney. With aging, both systolic and diastolic blood pressure increases, but above 60 years, systolic blood pressure increases and diastolic blood pressure reduces, which leads to the wide pulse pressure. The different guidelines give different goals. The lower tolerated goal is better in elderly as they are vulnerable to orthostasis, falls and renal dysfunctions. One size may not fit all, so there is a need of the personalized medicine in elderly. European guidelines are more feasible in elderly with poor vascular compliance, orthostatic hypotension and wide pulse pressure. Issues like cognitive impairment, comorbidities, polypharmacy, orthostatic hypotension, falls, gait speed, medication cost and side effects, incontinence, fatigue, visual and auditory limitations, social support, caretaker availability and frailty should be taken care of. Non-pharmacological interventions contributing comorbidity and medication review are very important in them. Thiazide diuretics, AC inhibitors or ARBs and calcium channel blocker are the first line monotherapy in elderly. Combination therapy, calcium channel blockers plus thiazide diuretics or calcium channel blockers plus AC inhibitors or ARBs are good. Beta blockers, loop diuretic and alpha blockers, they are best avoided in elderly. Thank you. Thank you very much for your patient listening.
Thank you so much, sir, for your such a wonderful lecture. I now, are there any questions? The house is open for questions now. So, thank you so much, sir.
Thank you.
Thank you, sir. So now I invite Dr. A K Singh for giving memento to Dr. Vikas Agrawal, sir, as a token of respect from Heart India. Now once again I request Dr. Akhilesh to give memento to Dr. Bhupen Verma. Now I request Dr. M K Srivastava sir to give memento to Professor Lalit Meena. Once again, I requesting Dr. M K Srivastava to give memento to Dr. Soumik Ghosh. Now I request Dr. Umesh Pandey to come on the stage to give memento to Dr. Jigyasu Singh. Once again, I request Dr. Pandey to give memento to Dr. Harshit Jain. So today academic feast came to the end, and every year I used to start the CME and end the CME. Now this year, the responsibility of giving vote of thanks I am giving to Dr. M K Srivastava sir. Sir, please come on there and close the CME.
हाँ ठीक है ठीक। हार्ट इंडिया कॉन्क्लेव की तरफ से जो मैराथन पाली खेल रहे हैं, लगातार 11 साल से आलोक जी कॉन्फ्रेंस को आयोजित कर रहे हैं और इसमें इस बार हम लोग लाइफ टाइम अचीवमेंट अवार्ड दिए अपने गुरु जी को, डॉक्टर पी आर सिन्हा सर को, तो रोहित तिवारी जी को। तो एक ऐसा प्लेटफार्म है कि आपको दिन प्रतिदिन निरंतर हार्ट इंडिया कॉन्क्लेव की जो मैगजीन आती है, जो जर्नल आती है, उसको आप पढ़ते होंगे। धन्यवाद की कड़ी में सारे पार्टिसिपेंट के बिना कुछ पूरा नहीं हो पाता। सारे पार्टिसिपेंट को हार्दिक शुभकामनाएं में बधाई। सुबह 9:30 से आप लोग आए थे और 7-8 बज गए। और BHU के फैकल्टी हमारे सीनियर AK सिंह सर और जो नहीं है सर पी आर सिन्हा सर ओपनिंग बैट्समैन की तरह शुरुआत करते हैं हर बार। तो पी आर सिन्हा सर को बधाई, शुभकामनाएं सभी को। धन्यवाद ज्ञापन की कड़ी में बहुत चीज़ें करनी होती हैं, लेकिन आलोक के डेडिकेशन को सलूट है। आलोक हम लोग के बहुत जूनियर हैं, लेकिन ये बहुत ज्ञानी पुरुष हैं, इन द सेंस कि ज्ञान अच्छे इंसान भी हैं और मेरे डिसिप्लिन में रहते हैं और डिसिप्लिन चाहते हैं। तो इसलिए हम 15 मिनट पहले आ जाते हैं, इनके पहले आ गए थे आज। तो डेडिकेशन जो भी दिखता है तो उसको हम लोग सैल्यूट करते हैं और उसी हिसाब से हम लोग आगे के जो हार्ट इंडिया कॉन्क्लेव होगा उसमें और विधिवत और अच्छे से किया जाएगा और इसको एक मुकाम तक पहुंचाया जाएगा। विश्व में हार्ट इंडिया कॉन्क्लेव का जर्नल तो चमक रहा है, आलोक जी भी चमके। इसी के साथ धन्यवाद। हम डिनर के लिए आमंत्रित करते हैं सभी को ऑन द बिहाफ ऑफ हार्ट इंडिया कॉन्क्लेव और सभी को बधाई, सभी को शुभकामनाएं। धन्यवाद।